Top Bed Talk.
Hello everyone, I'm coming to you from Melbourne in Australia. So thank you very much for your kind invitation to speak at the Dingle meeting. I'm going to talk about depth of anaesthesia and long-term outcomes. The opinions that I'm going to express in this talk are my own, and they don't necessarily reflect those of my organisations. And I have no potential or actual conflicts of interest to declare in relation to this presentation. So this time last year, we were in Orlando living it up on the Top Med Talk stand in the healthcare exhibition. And then in June before that, we were at Croke Park in Dublin at the Irish meeting. And those were the days, and I wish we were meeting together in Dingle. But unfortunately, 2020 happened, and things have not been the same since then for any of us. For me, we've been in lockdown in Melbourne for nearly 12 weeks. I can't go more than 5 kilometres from my house. I have to wear a mask outside, and I have to dress like that the whole time I'm in the hospital. And all of my meetings are by Zoom, and a lot of my talks and so forth are being done in the middle of the night in North America. So this is the new COVID normal, and I really hope it doesn't last too long and that we are back all having fun together in the very near future. Anyway, it's a great relief to be talking about something that's interesting and that it's not about COVID. So today I'm going to talk about perioperative outcomes for the elderly, talk about depth of anaesthesia and mortality, and then give you some breaking news on depth of anaesthesia and delirium. So more than 300 million patients have surgery annually worldwide, and an increasing proportion of them are elderly and at risk of perioperative adverse events. There's very few proven primary or secondary prevention measures, and the resources for monitoring and treating complications are inadequate. So more action is required. About 10 years ago, my friend David Story led a study in Australia and New Zealand called the Reason Study, where we looked at about 4,000 elderly patients. 68% of them had a comorbidity. And at 30 days, 5% of them had died. That was 1 in 20. 9% had had an unscheduled intensive care unit admission, and 20% had suffered a major complication. And you can see the risk factors for mortality over there on the right, including increasing comorbidity and age, thoracic surgery, and hypoalbuminemia. So we set about trying to find measures that would prevent major perioperative events, particularly in the elderly. And so far, we have not found the silver bullet. Beta blockers prevent MI, but they cause stroke and death. Clonidine, aspirin, and restricted IV fluids have no benefit and have risks. We've done 2 studies looking at the emission of nitrous oxide and shown no benefit of that. And epidurals and statins have been very difficult to study, and there's insufficient evidence about whether they are beneficial. So we've turned our attention to depth of anaesthesia. Now, you all know that anaesthetic requirement varies between people, and one of the most important factors is the patient's age. Over on the right, you can see the relationship between age and the fraction of MAC, with the midpoint there at 40 years. And you can see what a substantial reduction in MAC there is when at advanced age. So what this means is that elderly patients are at risk of anesthetic overdose. And this is an interesting study that illustrates that really nicely. You can see that this is at 2 hospitals, and the y-axis is the delivered MAC, and the x-axis is the age. And the dotted line is where the person is getting the right amount of anaesthetic for their age. And there's unadjusted MAC on the left and adjusted MAC on the right. And what these graphs show is that anaesthetic delivery decreased with age, but not enough to account for the decreased anaesthetic requirement. So on average, elderly patients were getting an absolute anaesthetic overdose, and it was very common. There's another phenomenon where people who look similar to each other still vary quite a lot depending on some known and unknown factors. And so sometimes a delivered concentration that would be appropriate for most similar patients of the same age results in deeper anaesthesia than expected. And these patients have what we call anesthetic sensitivity, and they've received a relative anaesthetic overdose. Now, whether this anaesthetic sensitivity is actually just an intermediate factor between the real cause of their problems and the outcome is unclear and is the subject of more study. So we have a rather large problem, and it's getting larger in that there are increasing numbers of elderly patients who are presenting for surgery, that we don't have any safe or effective measures to prevent major adverse events. We know that elderly patients are at risk of absolute and relative anaesthetic overdose. So we need to find out if avoiding deep anaesthesia is a way to improve outcomes for elderly patients. So now I'd like to take you on a journey through the observational and randomized trials to the balanced anaesthesia study to show you the effect of anaesthetic depth on mortality. So the first study was from Monk and colleagues in Florida, and they looked at about 1,000 patients having non-cardiac surgery. All of them were BIS monitored, and the patients were blind to, the anaesthetists were blind to group allocation. And what Terry Monk showed was that multiple comorbidities and hypotension were risk factors for death. This was one of the first times that it had been shown that hypotension was a predictor. But there was a new variable that was developed for this study, which was called the cumulative deep hypnotic time. And this was the time that BIS was less than 45 during the case. And that was, you can see the relative risk there was 1.24. So Neil Cohen wrote an editorial about this paper, and one of the major criticisms was the arbitrary definition of deep hypnotic time, and the fact that the deep hypnotic time was defined using the BIS, and therefore that there was an implication that BIS is critical to avoiding deep hypnosis. And we disagree with Cohen. We think that this is critical to avoiding deep hypnosis because there is no way to tell if someone has anesthetic sensitivity unless you measure the effect of anesthetics on their brain. In any case, the paper and the editorial caused an uproar and launched 1,000 studies and editorials and commentaries about this issue. The first study looking at burst suppression was from Watson and colleagues at Vanderbilt. They looked for EEG burst suppression in sedated, critically ill patients. And what they showed was that while ICU mortality and hospital mortality were not significantly associated with burst suppression, 6-month mortality was. It was a more than 2-fold increase. Now, the problem with burst suppression, particularly in the critically ill, is that it's not always clear whether it's due to excessive sedation or whether it's due to some kind of brain injury. So that needs to be sorted out further. We did an analysis of our Be Aware trial data. Just to remind you, that was in 2,500 patients having all types of surgery, where 50% of the patients are routine care and 50% of the patients were BIS monitored. Our patients were older and sicker than the Monk patients and also the other patients studied by Lindholm. So patients, there were 50% who got no BIS and 50% who got BIS. And of the BIS patients, only about a third are BIS of between 40 and 60 for the whole case. And the low BIS patients had a BIS below 40 for at least 5 minutes. And we don't know why the BIS was low. The anaesthetist could have intentionally targeted a low BIS. They could have allowed the BIS to remain low. or they could have tried to increase this but been unable to do so. So we looked at long-term mortality. This was 4 or 5 years later, and it was 22%, which they were a pretty high-risk group of patients. And you can see that age, ASA status, and hypotension were significant predictors of a poor outcome. Now, patients in the no-BIS group probably had a low BIS, which is why they weren't any different from people in the low BIS group. But you can see that patients who complied with the protocol, they did a lot better than the patients in the no-BIS group and in the low-BIS group. So what this implied was that patients who had a BIS over 40 for the whole case did better. And that also panned out for myocardial infarction and for stroke. And our study is the only one that's really looked at all three of those major long-term outcomes in the same group of patients. So there was an editorial about this study as well from Dr. Kurata, and he raised some concerns, but the one I'd like to highlight was that we lacked a detailed hemodynamic data collection in the Be Aware trial. So we were unable to say whether there was the same amount of hypotension in each of the groups in the study, and hypotension is probably the major confounding factor. So Willingham followed up on the work of Watson with more inquiry about burst suppression. And in this paper, they looked at 90-day mortality in a cohort of 104 patients. And you can see that, once again, age and malignancy were predictors of a poor outcome, but that neither a low mean arterial pressure nor EEG burst suppression were predictive on their own. But you can see that a combination of the two was predictive. And this is sort of consistent with the triple low work that I will talk about in a minute or two. So Tim Short and I wrote an editorial about this one, and we ripped off Donald Rumsfeld with his idea of known unknowns and unknown unknowns. And we pointed out that the problem with observational studies is that you can only account for the known knowns, that is, the measured variables. There may be unmeasurable variables that you know about, but the biggest problem is the unmeasured variables that you don't know about. And the only way to ensure balance between the groups for all the types of variables is to randomize. So here's a summary of the observational studies. The ones up the top show an association, a significant association between a low BIS value or burst suppression and a poor outcome. And the ones at the bottom show no significant association. So we've talked about observational studies, but now I'd like to talk about a different sort of observational study, which is the triple low studies. And these were initiated by Sessler and his colleagues at the Cleveland Clinic. So in this study, they took a large database and they looked for the median or mean MAP, BIS, and MAC. And they defined a standard deviation of values in the data set, and a low was defined as something that was one standard deviation below the mean. So then they defined three different lows: a low MAP, a low BIS, and a low MAC. And the people with a low MAC had anesthetic sensitivity, or they weren't delivered very much anesthesia by their anaesthetist. And you can see there in the middle panel that the only single low that's significantly associated with increased mortality was low MAC. If you look at the double lows, only the double lows that included low MAC were significant. And then the triple low was associated with a fourfold increase in 30-day mortality. You can also see over on the right-hand panel that it seems that in this study, you need at least 15 minutes of cumulative triple low before mortality starts to take off. So this study had an editorial as well, and they asked, is the triple low detecting patients with increased risk of mortality? Like, is it another kind of intermediate variable? Is hypotension the stress test in patients with frailty, as demonstrated by anesthetic sensitivity? And if triple low is causal, is the hypotension, the EEG burst suppression, or both the thing that matters? So here's a summary of the triple low observational studies. There were a number of studies that followed that I haven't mentioned here, none of which strongly supported the result that was seen by Sessler in the original study. So I think what needs to happen next with this work is to try and work out which factor is the most important, and it's probably the low MAC. But what this research has spawned is a great deal of inquiry into low blood pressure. So the whole observational study thing has been accompanied by editorials with cool titles, some of them written by Tim and me, and we apologise for that. But after all of this, in the end, only an adequately powered randomised trial can answer this question. So observational studies, they've got a risk of bias and overestimation of the effect. The associations with poor outcomes in this area have been inconsistent, and they are unable to untangle the effect of anesthetic sensitivity. They're unable to determine causality, and we need RCTs. So speaking of RCTs, the first big one was done by Matthew Chan in Hong Kong, and he was studying delirium, and I'll show you this study again in a minute. But now we're going to just talk about the data about mortality. So there was a routine care group and a BIS group. They got good separation between the groups. They're very good at doing that in Hong Kong. And there was a big difference between the MAC values in each of the groups. There was a fair bit of hypotension, but it wasn't significantly different. And you can see that there was no difference in 90-day mortality between the two groups. But this was a relatively fit group of people. The next study is the DELIGHT study, which was conducted at the Cleveland Clinic. And this trial was stopped early because of futility. What they were attempting to do was look at 3 anti-inflammatory strategies: dexamethasone, light anesthesia, and tight glucose control. And you can see over on the right-hand panel why the study was unsuccessful, and that was because they failed to get enough group separation between the light and the deep group, even though the percent of time that the BIS was really low was a fair bit more in the deep group than the light group. Then there were a couple of studies that were conducted looking at delirium in hip fracture patients, where they did a secondary analysis looking at mortality. And this one was from Brown and colleagues, and they did a number of different analyses. So at the top here is all of the patients, and this is the proportion who were alive and over the year. And you can see that there's no difference. But down at the bottom, here are the less well patients, the ones with a Charlson score of greater than 4. And you can see here that deep sedation was associated with a worse outcome in these comorbid patients. So we wrote another editorial about it, this one, and in this one we talked about small sample size. Small sample size brings a risk of imbalance in baseline characteristics, which was actually realised in this study. And there's a low prior probability of finding true effects. There's a low positive predictive value for the claimed effects. And there's exaggerated estimates of effect size for true effects, which is called the winner's curse. And the confidence intervals are usually very wide. So this group did another study. It was called the STRIDE study. And this is the second paper from it. And in contrast to the previous study, they were unable to show any difference in the depth of the sedation between the two groups. Although there was a little bit of different, a suggestion of that delirium severity was important, and also the Charlson score. So here's a summary of the randomized trials that have been done to date. A couple of them I have not mentioned, but none of them show a really significant difference between the two groups in terms of outcome. So what we need is to avoid small sample sizes and inadequate separation between BIS groups and lack of generalisability. We need a well-designed, purpose-built and well-conducted randomised controlled trial. So that's what we hope we did. So as a preamble, just to tell you about sort of the rationale for our study design, the idea is that low BIS values cause death. Now, that's way too simplistic. If you don't use BIS titration, then you can't tell the difference between people who've got low sensitivity or normal sensitivity to anaesthetics and people who've got high sensitivity, and you get into this situation of giving people an overdose. If you give people too much anaesthesia, you can cause organ toxicity and immunosuppression, or you can also cause organ hypoperfusion and ischemia via hypotension, and they're probably really the things that are associated with death. So the way to get around a lot of these confounding factors is to use BIS titration to try and avoid overdosing people who are sensitive to anaesthetics, and to make sure that the blood pressure is the same in the two groups. So the balanced anaesthesia study was an international randomised controlled trial conducted by the ANSCA Clinical Trials Network. It was the latest in a long chain of studies that started with the master trial. We've done upwards of 10 trials now, including some fantastic international collaborations. Our latest study is the PADDY study that hopefully will be published soon. And Thomas Corcoran, the chief investigator, is planning a worldwide webinar to launch that trial. So watch this space. I'd like to acknowledge the chief investigators of the balanced anaesthesia study. Tim Short was our leader. He's an anaesthetist in Auckland. Doug Campbell is also from Auckland. He did all the data management, all the mountains and mountains of BIS files and things. Davina McAllister was our trial manager, and Chris Frampton was our trial statistician. And I always say you can tell he's the statistician because he's not smiling. We had great committees. We got great support from the project office at the Auckland City Hospital and from the Trials Network office at the college. And we had a fantastic participating centres, 74 of them in 8 countries, and hopefully some of the great contributors are online at this meeting where I can thank you again personally. Tim Short declared a couple of consultancies, but none of the other investigators had any conflicts of interest to declare. And all of the funding came from national peer-reviewed funding. There was no support by the makers of the BIS monitor. So our hypothesis was that light anaesthesia, a BIS of 50, reduces all-cause 1-year mortality compared with deep anaesthesia, that is a BIS of 35, in elderly patients presenting for major surgery under volatile-based general anaesthesia. The participants were elderly with comorbidities having longish surgery, and the exclusions included propofol infusion, nitrous oxide, too much ketamine, brain surgery, and wake-up tests. We asked the anaesthetist to nominate a target mean arterial pressure range before they found out which group the patient was in, and we asked them to maintain that range during anaesthesia. And we also asked them to keep the BIS within 5 BIS units of the target. They had to use volatile anaesthetics, but otherwise everything else was up to them. As I said, the primary outcome was 1-year all-cause mortality, and we had a range of cardiovascular, infective and health service and patient-centred outcomes. We modelled a sample size reduction as follows, from 10% to 8%, requiring 6,500 patients. And we had a pre-specified intention to treat population and per protocol population. Out of 18,000 eligible patients, we enrolled and randomised 6,668 patients. And we only lost a few during the study. The patients were elderly. 2/3 of them were male and 1/3 were female, and they were a little bit overweight. Most of them were ASA physical status 3. We failed to recruit as many ASA 4 patients as we wanted. About half of them were having intra-abdominal surgery, and about half of them were having surgery for cancer. We achieved about an 8 BIS unit difference between the two groups, which wasn't as much as we wanted, but it did represent a substantial difference in the MAC delivered in each of the two groups. BIS targeting was difficult in about half the patients, but we managed to maintain excellent mean arterial blood pressure, nice and high, and that really struck out any suggestion that blood pressure was a confounder in this study. And you can see that those mean arterial pressures were largely achieved with vasopressors, at least intermittently. Here's a graphical representation of the targeting. You can see good separation in BIS and MAC and not so much in MAP, so that was what we wanted. And here is the information about the post-operative period. You can see here that there were no big differences in PACU stay, quality of recovery, hospital stay, or disability. Here's the 1-year mortality data, which is the primary outcome of the study. And you can see that there's absolutely no difference between the two groups. The mortality in the high group was 6%, and in the low group was 7%. And here are the secondary outcomes, and there were no significant differences between the two groups in terms of cardiovascular, septic, health service outcomes, and there was one case of awareness in the light group, which was partly associated with technical and decision-making issues rather than the randomisation itself. There were a couple of quirky things that happened with some of the pain outcomes. These were very much secondary outcomes, and we're not drawing any conclusions about depth of anaesthesia and neuropathic pain at this point. And these are the per-protocol analyses. The demographics and the perioperative data were very similar, and the BIS separation was similar, the MAP was good, and there was absolutely no difference between the two groups in the per-protocol analysis. And here's an updated meta-analysis, and you can see that the pooled odds ratio is 0.93 and the 95% confidence intervals are 0.79 to 1.10. So the strength of our study is that it's the largest randomised controlled trial of anaesthetic depth to date. There was adequate separation of BIS and MAC between the groups, and there was comparable MAP in each of the groups, so that was great. The limitations include that only 5% of the patients were ASA physical status 3 or 4, that it was difficult to track the BIS in a lot of the patients, and therefore the separation wasn't as good as we would have loved, and that the incidence of the primary outcome was lower than expected. So there's been some commentary to suggest that the study is underpowered. We think that it is unlikely that there is a large difference in the outcome between patients in the deep and light groups. We can't imagine why anyone would want to repeat this study. It took 10 years and a lot of grey hairs to finish it, but we've had a great sense of accomplishment at the end, in any case. So we conclude that when compared with deep anaesthesia, light anaesthesia does not improve 1-year survival and does not increase the risk of awareness during anaesthesia. The balanced anaesthesia study defines a broad range of depth over which anaesthesia may be safely delivered in older comorbid patients, and it supports the safety of anaesthetic titration using processed EEG monitors because the incidence of awareness was low. So what do we advise? Well, please consider using age-adjusted MAC values and TCI algorithms, and actually follow their advice about the delivery of anaesthetics to elderly people. Consider using a processed EEG monitor because it will help you diagnose anaesthetic sensitivity, and it will also help you with the differential diagnosis of causes of hypotension. And avoid anaesthetic-induced burst suppression. At the very least, it's wasteful of anaesthetic to give too much. So now I'd like to talk a little bit about depth of anaesthesia and delirium. The study that kicked this all off was this very well-known study from Moller and colleagues, and there was quite a lot of evidence in this study that anaesthetic factors, which are identified by those purple arrows, that anaesthetic factors were associated with poor neurocognitive outcomes. And why would that be? Well, anaesthetics cause hypotension and immune suppression, and these things can cause organ ischemia and toxicity and lead to death and disability. Our friend Liz Everard has written a lot on this topic, and she has pointed out that there is inadequate research on preventing post-operative neurocognitive decline. And she listed a range of things that needed more attention, and one of them was the effect of depth of anaesthesia. So these are the studies that have been done about EEG guidance and delirium, and you can see that in general the sample sizes are small. There's a wide range of surgery, a wide range of different tests for delirium, and a wide range of follow-ups, and a wide range of different measures of anaesthetic depth. So it's all a bit of a schmozzle at present. One of the first studies was done by Sieber and colleagues at Johns Hopkins, and I mentioned this study before. They were looking at hip fracture patients, and patients were randomised to deep or light sedation during spinal anaesthesia. So you can see here that the patients were elderly, and quite a lot of them had preoperative dementia, and you can see that there was baseline imbalance here in terms of how many of the patients were independent at home. And this is one of the problems with a small study. And you can see that there was a lot more delirium in the deep group than the light group. And the predictors of delirium were the BIS values, pre-op dementia, red cell transfusion, and intensive care admission. This is Matthew Chan's study, and it was about 1,000 patients. They're really great at getting separation between their BIS values in Hong Kong, as I said before. And you can see that there was a significant increase in the amount of delirium and post-operative cognitive decline in the patients who had standard care, and those standard care patients had a deeper depth of anaesthesia. A German group has looked at this, and unfortunately in their case they were unable to achieve a really big difference in BIS values between the two groups, although there was a significant difference in the number of patients who had BIS values less than 20 and who had burst suppression in the standard care group. And probably because of that, you can see that there was an increased risk of delirium in the standard care patients. This is an observational study from the Washington University. These were patients with intraoperative EEG burst suppression. And you can see that the incidence of delirium was about 26%, and that low MAC and high burst suppression were associated with delirium. And burst suppression was associated with high MAC and low amounts of opioids. I guess that's why you need high MAC if you're not giving people enough opioids. This was Sieber's second study, which is the STRIDE study. So you can see that they were quite old, and there was a lot less preoperative dementia in this study than in their previous study for some reason that's not clear. And there was a lot less patients who were dependent on nursing home care. You can see that the BIS values were pretty different between the two groups, but the risk of delirium was the same. So they sliced it and diced it, and funnily enough, they looked at the hazard ratio for death with deep and light sedation, and the hazard ratio for delirium with deep and light sedation. And deep sedation was only a significant risk factor for delirium in patients who were completely fit, and not in patients with higher Charlson comorbidity scores. So that's a bit of a puzzle, and it probably relates to the fact that people with higher scores have got a bunch of other things causing delirium, and that the effect of the anaesthetic is sort of swamped. So in short, this study didn't really give us any really good information about whether deep sedation was hazardous or not. So this is the largest study. It's the Engages study from Washington University in St. Louis. And they randomized 1,200 patients having major surgery to a package of delirium prevention, which included lots of things, but an instruction to the anaesthetist to avoid burst suppression during the case. So here's the EEG guided group and the usual care group, but that was actually a package of care there. And you can see that the EEG guided group used a bit less vasopressor. The duration of this of less than 40 was shorter. And that although they were supposed to avoid burst suppression altogether, there was still a substantial amount of burst suppression in the EEG guided group. And they showed there was no difference in delirium between the two groups. And that one reason for that might be that they were unable to avoid a dose of burst suppression in this side of the group. So that didn't really it caused a lot of controversy, and we're not sure what all of that means. So here's a summary of the outcomes. Most of these studies have shown that deep anaesthesia is associated with more delirium, except for the largest study, which is Engages. So we did a sub-study of the balanced anaesthesia study. This was led by Liz Everett from St. Vincent's Hospital and now the Weill Cornell Medical Center in New York. And the participating centres were Weill Cornell, the Hospital for Special Surgery, the Cleveland Clinic, St. Vincent's in Melbourne, and the Chinese University of Hong Kong as the chief investigators. This work is unpublished, so I'd prefer it if you didn't sort of tweet around the data too much or at all. So this is the patients. Now, it was only done in 5 or 6 centres, and the patients were slightly different, mainly because there were more patients from Hong Kong. So the same age and male-female split, they're a bit thinner. About the same number were ASA 3, but more of them were having intra-abdominal surgery and more of them were having surgery for cancer. There was an excellent split between BIS values in the light and deep group because more of the patients were from Matthew Chan's centre in Hong Kong. The mean arterial pressures were nice and high, and there was great split between the MAC in each group. Lots of vasopressors were used, but more in the deep group. And there was more burst suppression in the deep group than in the light group. You can see that post-operative delirium was pretty common on the first post-operative day as measured by the CAM, that it fell away over time. But there were still patients who were positive for the CAM test on day 5. And this was all conducted by trained investigators. And here are the outcomes. You can see that there was a significant decrease in the risk of delirium in the light group. And you can see that the mini mental state exam was not different in any way between the two groups, but that there was a statistically significant difference in the number of patients who had cognitive decline at 1 year. So deep anaesthesia is associated with lingering drug effects, hypotension, and immunosuppression. EEG monitoring can be used to avoid deep anesthesia and birth suppression. And randomized controlled trials suggest that using EEG monitoring to prevent deep anesthesia results in less post-operative delirium. So I think the balanced anesthesia sub-study has really established that avoiding deep anesthesia for the purpose of avoiding delirium is a good idea. Thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.